Good afternoon and welcome to the Independent Scientific Advocacy Group Public Meeting. This week we are going to have a conversation. We invite you to join the conversation and to submit questions where we are going to discuss the significance of the new B.1617.2 variant, first identified in India and now growing in the UK, specifically England, and significance of that for Ireland. So the Independent Scientific Advocacy Group is a group of scientists, doctors, medics, and others who have come together to advocate for an evidence-based approach to pandemic management. And in that context today, we just want to talk about this new variant, what it means for Ireland, and also some of the concepts that are very important for understanding the decisions that we now face as a country. We don't have much data at the moment because, as everybody is aware, there has been this hack of the HSE computer systems, which mean that the data that have been released are extremely sketchy. And with that, we're not able to, it's very coarse level data, very rough numbers. So we don't have the usual detailed situation update that we would normally have. But it's still important in this context to understand what the decisions that we need to make are. We're going to be talking about the importance of things like increased transmissibility, what are we trying to do and how do we achieve herd immunity through vaccination? And just then also how to understand those vaccine efficacy numbers that we hear mentioned. But to start off, I'm going to ask Paul Dempsey to give the situation update in so much as he can with the data available this week. Thanks, Paul.
Okay, so the first piece of information we have is from Northern Ireland. If you want to just bring up the slides there. Yeah. Slide one. So from Northern Ireland, we have a picture of again, for the last couple of weeks, it's been relatively steady. One thing to note they're over 80s, they're a certain level, but the over 80s, the last time we had recorded values in the Republic were lower than they are in the Northern Ireland. So our vaccine rollout is actually in some ways going much better and having more of an impact. In the younger age groups, they have high values than average, which is normally what you'd expect. The one thing it's encouraging to think that they're stable, but the numbers in general are stable despite the fact that they're rolling out a vaccine. So the activity levels are matching that, and we'll see later in today's talk that it is still a degree of cases that matter because it's still important to keep a track of cases from both the end impacts and variant arrival. But one good thing to note from Northern Ireland is in the last 7 days they've had 0 COVID-related deaths. Okay. For the Republic, we have absolutely no useful data, which would be, by useful, I mean broken down by age groups, broken down by status of vaccination, broken down by whether they're healthcare workers or non-healthcare workers. We don't even have broken down by counties other than what we're hearing in the news of outbreaks in Limerick and some citizen science collecting data from schools to give us some sense of what's going on, but it's not complete either. Okay, that's it for Aoife on that.
Thanks, Paul. Yeah, so so much less information than we usually have. But I mean, I think, you even mentioned there, I think, an interesting point that the numbers are relatively stable despite the vaccine rollout and how that might signify something. Like, what do you think that means?
Well, it's most likely that we were kind of accepting that we can increase amount of social activity and vaccination will make up for that in total case numbers. And generally people are still going to accept that. Seems to be the attitude now. We can live, or the attitude seems to be a general attitude, we'll live with this and hopefully bad things won't happen. And if they do, maybe then we'll react. But I mean, the worry is that you get some changes like with what we're seeing in the Indian variant in the UK in Bolton, where the hospital, even though that their vaccination rollout is going much better than ours, and it's not like Bolton is pretty much the same vaccine rollout as the rest of England as well, but they've got 42 or something people in hospital in a metro area that's about 18 times smaller than Ireland. So it'd be the equivalent of hitting us now with around 700 a couple of hundred case hospitalizations, which at any time wouldn't be good, but with the HSC systems the way they currently are, the hospitals outside Dublin would have a lot of trouble managing that at the moment, and that's one of the things. We're in a very precarious position with because of the hack.
Yeah. I mean, it made a bad situation even worse. I mean, it's such an entirely malicious hack. But with regard to the B.1617.2, this variant that's first noticed in India, but of course is now, as you mentioned, it is rising in England, and Bolton is one of the places. So this has been labeled as a variant of concern. And so a variant, lots of variants exist. That just is talking about there's genetic variability. This is totally normal. But when something gets labeled as a variant of concern, it can be for any of three reasons. So it can be increased transmissibility, it could be worse disease outcomes, or it could be some kind of vaccine evasion or lower efficacy of the vaccines. So the current situation is that it is thought or suspected, or there's certain question marks over the transmissibility of this B.1617.2. And this increased or proposed or expected increased transmissibility of this variant is that on its own is worrying. And I think this is something that needs to be explained, just for the general public to understand, because I think it isn't always immediately obvious to people why having increased transmissibility is a problem if the disease statistics don't look like they're changing. So I thought maybe, Paul, you could help explain this concept.
Yeah, sure. Yeah, I suppose I don't want to over-egg the situation with the B.1617, because the data from Public Health England was on relatively sparse amount of data sets. It looks like it's 50% more transmissible, but there's a couple of reasons why that could be an overestimate. So, for example, it could be that the housing situation that those people who have it living in are worse than average, so there's more intense spread early on. It could be importations from India being higher than expected. It could be that some of it is contributed from evasion of people who were previously infected, so reinfections, and that will make it look faster than B.117. And it could be from evasion of the vaccines. All these things could mean that it's not as raw, but we won't know that for 3 weeks or so. Mm-hmm. And the last time we did something for 3 weeks was before Christmas, and it landed us at 5 months of this. Yeah. So, it's a case of waiting, and maybe trying to keep that out until we know a bit more of, and also that gives us time for vaccines to work. I think there's we have a slide there to kind of roughly explain what transmittability looks like, and why. So in this kind of here we have, sorry, is it? So
yeah, that's great. I see.
Yeah, two examples. So one is where we have 50% more transmission, so it's multiplied by 1.5, the rate at which you transmit. And the other example is where you double the death rate. So doubling the death rate sounds like it should be worse, but it really isn't. So you start off with one person, and in the case of 50% more transmittable, you're getting 3, where previously you would have got 2 people infected. And that's just the second generation. And then in the third generation, you get more. And the fourth, you can see how it really does it. By the time you get through only a very small number of generations, so that's 4.5 days roughly for each generation, you get to a much larger number of total cases. And if you pick off 1% of those numbers, you end up with around 3 people dead. Whereas if you pick off 2% of the original situation, you only end up with 1 dead. So even though on the face of it, it looks like it's twice as worse, you actually end up with 3 times more deaths in that time period, which is very short time period.
So in this, you have the little the black shading is the individuals who died in your yeah. So and then there's we're starting at the top and going through the one person passes it on to 3 people on one side and passes it on to 2 people on the other side. So we end up with that much bigger number of cases in every step, but it's really, really dramatic on the 4th line down, the 5th line down, and the 6th line down, of course, is really, really big. Yeah. So so you just have, so even with a 1% death rate, you end up with more people dying. And I think that's that is, I think, the important thing about the increased transmissibility, that what we've been doing for the last 15 months is trying to stop people getting infected. And increased transmissibility just makes it much harder to stop people getting infected, of course.
So, yeah, for example, if we had stopped B.117 from, or slowed it down sufficiently, because unlike most of Europe and the UK, we didn't get really hit with a wave of B.117. We went into lockdown before B.117 hit. So most of our cases and deaths came from the variant that was before then. It turned out that B.117 killed more, as well as being more transmittable. It was also more virulent, which isn't really that surprising, because they will sometimes go hand in hand. So what you ended up with, instead of, we were on a track after Christmas when we locked down to really, really fast suppression of the old variant. It pretty much went away, and we were left with a declining, but slowly declining number of the B.117 variant. If it turns out that this B.1617 is more transmissible again, the cases will just go up in the same type of situation we're living in. Once you've any kind of social interactions, I suppose we'll talk in the herd immunity in a minute, we'll see why that matters and how many people you kind of interact with matters. But it's all about rate of transfer and how quickly that can happen. Of course, the one thing we didn't do in that slide is show how public health can really help. So if you just go back and show the slide for a second, if on each of those steps you're able to take out one person, you really make the problem a little bit less. If you're able to take out two people, you can see that the second one, you could actually have, okay, it's a really transmissible disease, but we're able to take out everybody at that second stage, so the disease can't go any further.
So you mean, when you say take out, you're meaning breaking those chains of transmission. So instead of one person, so instead of one person infecting three, they would just infect 1 or 0 if you're managing to successfully break the chains of transmission.
Yeah, so they'll infect the same in the first step, but you get your contact tracing in place. On all, so that's simplifying it, on all the investigation tools that public health use, and they isolate those people. And I think in Australia now they're talking about going to the 3rd level of contacts already. So not just those who you've made direct contact with, but their contacts as well. So rather than having to depend on lockdowns as a control mechanism, you extend out and only lock down people who are who've kind of a chance of having been in those chains.
Yeah. And I think that makes a huge amount of sense. And I think that's the kind of measure, I think, that makes a huge amount of sense to people, that, it's not that I'm staying at home all year because there's some virus in the country. I'm staying at home for 3 weeks because I was in contact with somebody or in contact with somebody who was in contact with somebody who is infected. And but it requires that public health resourcing, and it requires that level of information and people keeping track of their contacts and all of those kind of things. But it's a very targeted measure, as opposed to what we're doing.
Yeah, I suppose some of the things from public health people, I'm sure maybe Jerry can pop in later on it, is the compliance issue at that level, and if you have to do it too often. So you have to make sure you've got proper supports in place for people, and also you have to make sure that people can see the benefits. So in other words, that we keep it up and we don't end up in a lockdown situation continuously. And I suppose this is where it's important. One of the things we've done recently in Ireland is we've stopped testing close contacts who are vaccinated. That's a really silly approach, because vaccinated people can still transmit at a much lower rate, depending on which vaccine they've been given, but it still needs to be just so that we don't end up, so maybe we might be able to delay things by 3 to 4 weeks, but still we don't want to be back here in 3 to 4 weeks dealing with the problems.
That actually links in exactly, Paul, that links in exactly with the question that's come in. So it's from Nessa Childers, and she's asking, just that, what should those asymptomatic vaccinated people do when they are a contact? Should they remain isolated? So that's one question. And then, of course, the bigger question is, in the midst of all of these questions and uncertainties, how can we reopen? And that, I suppose, is the big question we are trying to address. But what would you say to that, Paul? Just generally, a vaccinated asymptomatic person who's a contact, I presume the advice is that they should act with great caution.
Well, in Ireland, we haven't given that advice very clearly yet, and there's definitely questions about the advice as for some people who are able to have bonuses after 4 weeks of a vaccine, which has very high chance of still transmitting. But in the UK, they've made it quite clear that vaccinated people are subject to the same rules as unvaccinated people for quarantining and things like that. Just for now, just until we're sure that the vaccines are able to get the time they need to do the work they need to do, so that we can minimise the amount of people who are affected between now and the time we hit sufficient vaccine coverage to do certain things.
And I suppose it's worth mentioning, so we mentioned already that with regard to the Indian variant, there is uncertainty regarding the transmissibility. Is how high is that transmissibility? There's other confounding factors that you've just mentioned that might be interfering with our ability to know. But I think what's important to remember is that in a few weeks, like you said, in a few weeks, we will know a lot more, because we'll be able to observe what happens in the UK. And in a few weeks, it will be quite clear. It's either that something unusual happened in Bolton, bad luck, a few different factors coinciding, or there's some biological feature of the new variant that makes it more transmissible. And I think the price of waiting those few weeks to have more certainty is quite slim. It's a holding pattern, but the potential cost of opening up now, if it is as bad as it might be, is really huge. And I think that's a point that needs to be made quite clearly. I think Jerry Colleen could come in here as well with something just to do with, we were talking about the high infection rates, and we were talking about, trying to figure out what's going on. And you had a point about the P1 variant, which is the one first identified in Brazil.
Yeah, thanks, Aoife. Yeah, I think it's people like one of our guests from a few weeks back, Tom Mallon. They, with all the data in the world, they couldn't put a number on the increased fatality associated with P1 in Brazil. And the reason for that is that you could explain all that increased mortality just in terms of the impact on the health system. So it was impossible for them to resolve the impact of transmissibility from the biological properties of the virus once it's in your body. And that's a very clear-cut example of how the end result of transmissibility can be just as important as the virulence of the virus itself.
Mm-hmm. Mm-hmm. Yeah. And all of these things interact, of course. It's and Paul already mentioned, the housing situation matters, because whether you've got space to isolate from the people you're living with or not is going to have a huge impact on whether or not you end up transmitting to them. So, if you're lucky enough to have, a spare room with an ensuite bathroom, it'll be much easier to do that than if you're living in cramped accommodation. And that's just obvious. It's just plain. But yeah, we try to disentangle all these things as much as we can. And of course, these decisions need to be made quickly and in real time.
Yeah. And I suppose on housing, it's one thing to remember. We are in a very, even on average, even well-off people in Ireland are in a poorer position than other European countries, especially Nordics, in that we stay at home until we're in our late 20s. So we've got younger people living with parents who are probably just about to get vaccinated. And of course, you've got the leaving cert to worry about right now as well. So we've got those type of things where a holding pattern makes sense to try and protect the leaving cert, to try and protect our health system with the ransomware attack, and also try to make sure that we can have a summer here, rather than having a case like last summer, like around Kildare, we ended up being locked down for I don't know how long, and like cancel holidays, and we just don't want to have to do that again and again.
No,
and again.
No, nobody does. But like you say, so we have, in this country, relatively high number of average occupancy per household, and even, family size. You talk about, so they've been talking about the Leaving Cert students trying to quarantine, but how can you quarantine when you're living in a house with people who are going to work, with younger siblings who are going to school and, potentially bring things home? It's extremely challenging. So I think it's a very tricky situation. But overall, I think one thing that we see is essentially the government policy, but not only the Irish government, is to try to achieve herd immunity through vaccination. So herd immunity is something we've heard mentioned in the early days of the pandemic, where there was this awful suggestion in some quarters, trying to achieve herd immunity through infection. But herd immunity through vaccination is a sensible thing. It's safe and it's really good. But I think it's interesting. I think it's important to understand, for people to understand in general, when do we achieve herd immunity, and what does herd immunity really mean when we're talking about this? How do we protect the general public? What's a sufficient level of vaccination that will then also protect that small number of people who, for whatever reason, the vaccine just doesn't take in them, and maybe a small number who can't take it for other reasons, maybe because they're too young, babies, etc., will be protected by the herd immunity. So how do we achieve herd immunity, and how would you describe it?
Yeah, well, I suppose the key thing with herd immunity is, I said, it was never, ever, ever going to happen through infection, because mutations that optimize were always going to happen, and it was always going to come back in again. It was never going to happen. Anyway, it was a murderous policy. The difference with vaccines is vaccines in general are much better than, even, never mind the fact that you don't die, even just from the protection they give, they tend to be much better than infection, at least the ones that are designed. So we already know from the Novavax and the 2 mRNAs that their protection they give far exceeds that of natural infection, and hopefully will last longer. So, for example, the HPV vaccine lasts much, much longer than the protection from acquired infection. So vaccines are, the amount of deaths you're going to get. We've seen with the mRNAs, we saw Israel blasted through it and they had very few health problems related to it. Tiny fractions, not even noticeable. AstraZeneca has questions, but for certain age groups, there's definitely the risks, the benefits far outweigh the risks of COVID. I suppose the issue, if we go on to, we'll talk about later, is the timing it takes. So with vaccine is the way to go. So I might just move on to the next slide, where we just kind of go through what infection looks like and what infection looks like in a normal situation. So we haven't been living normal for the last few months. Normally, on average, a person will meet 15 people-ish a day. Now, some of these people you meet every single day, and some of the people you meet the odd time. With no one vaccinated and no immunity in your system, every one of those people I meet, so I'm the red person there, I'm infected, every one of those 15 people per day I meet is at risk of me giving them the virus with some chance. Now, early on, this is about 5% chance. Now, based on the latest Public Health England's, the chance of this is a 1 in 8 chance. So on every day. So it's quite a lot. So these are highly infectious diseases when you meet people. But we're meeting a lot less people now, and that's why things are going down. And those people we meet, we're meeting them outdoors in general, or we're meeting them at distance, or we're being careful. So, for example, if we go, this is unvaccinated and the start. If we go just to the next slide and we see what happens after a couple of days. So let's just say day 5. I've recovered, or I'm no longer infecting people. So that could be for a few reasons. I could either be really, really sick, or I'm just recovered. I'm no longer able to infect people. But I've left these 4 people. Now these 4 people continue on and do the same thing to more people. The way there's the main ways we've had up until now. Yeah, so they keep going on. Now, if you've got a bubble community, so people live in a small community, it'll be only stay within that group. Likewise, if you can keep a community that has none of these people in it, you don't have to worry. Like, let's say Rathlin Island there, where they managed to just keep it zeroed. They just kept it out. And it's achievable. That's what the US military did in the early parts of 1918 flu as well in their bases. They just made sure that it wasn't possible to get in. Or when anytime it got in, you quarantined to make sure it doesn't spread. But if you just let it go as it is, you end up with a situation like this, and it just keeps going on and on and on. Even people who get infected, eventually that protection will wane, and it can keep going on again as well. If we go on to so this is at 5 days. So yeah, if you vaccinate people, and if it's 100% vaccine. So again, so I go into this population, half of them are vaccinated, and I go to the next slide and I see at the end of that, suddenly it's only 2 people in the next slide. Only two of those people get infected now. So we've halved it by vaccinating 50% of the population with 100% effective vaccine. And then if we go on to the next slide again, we'll look at a situation where so we increase the vaccination up to a certain level, and now there's still a chance of one of those 3 remaining people getting it, but it becomes so less likely that what will happen is the disease will come in and it will die off. So it might infect one person, but then the next person, he might not get a chance to infect anybody. So it'll end there and the chains will end. Again, this is with 100% effective vaccine. The person can't get it and they can't give it off. If we move on to the next slide and we look at a more realistic situation where you have a 50% effective vaccine from the point of view of transmission, so the people can get it, and then they can go up. But they probably won't give it off to the same amount of people because it'll break it down. But in this situation with COVID, the kind of values 50% effective will not be enough to prevent it going on. In fact, it could probably travel through an entirely vaccinated population, and that might sound okay, except it leads, and it might be okay long term if COVID settles down into some particular form. But as long as it can keep mutating in a new environment, you can get new strains and variants that might give more weakening of the vaccines. But if we go on to the next slide, we'll look at the kind of situation we've seen in Israel, where they have used a very effective vaccine on all of their pretty much all of their adult population to date, and it leaves a small cohort still exposed. But those who get infected are less likely to transmit it off. And the only worry you'd have is this is a very personal thing. So it's about who you meet. So if you live in suppose we were to get 100% of people in Leinster and Munster vaccinated and very few in Connacht, that won't, and the national average will say we've reached 80%. That still won't say that the people in Connacht are magically protected by people far off in Leinster and Munster. And like that, we tend to meet people of our same age groups or our parents or grandparents. So if it's a case that our parents are all vaccinated and they're making their parents, they should all be fine. But if we go down to the children and younger children up to, say, 12, where there's not yet approved vaccines, they would mix a lot with each other. They can give it off to each other. Now, their outcomes might not be so bad, because even if we look in Brazil, most of the deaths in children have been in babies, in 0-year-olds, which is kind of what you'd expect. And that's why with measles, why we can't vaccinate the zeros, but we vaccinate from 1 up, and measles gives you, and that protects them indirectly. If you have this situation of COVID, and it's the kids who all have it, what ends up is you're going to need more than near 80% of adults to protect the adult group in general, because they're kind of like a constant pressure testing out the vaccines. Now, if the vaccines are 100%, there would be no issue, but there's no vaccine that's 100%. For Pfizer, for example, it's a 30-fold drop in the deaths, which is absolutely incredible.
Brilliant, yeah.
But what it really does is it makes this month's numbers that we think are the numbers going around right now, with people vaccinated, the risk is the same as around last June, when we naturally brought down the levels to a really low level. So we think we overestimate and underestimate certain things.
Explain that to me there. So you're saying that our high numbers now, with the number of vaccinated people around, the comparative, did you say okay.
So this last June
are similar to last June.
The risk is similar to last June. So last June, we had 30 times less virus going around. So you have 30 times less chances of getting the virus, whereas now you have 30 times less chance of dying from it. So they balance each other out in that way. Not so simple, because of course last June if you put in some imports, it gets worse really much quicker. Whereas now it would take a while for it to get into a worse situation, depending on how transmittable those new variants are.
Yeah, the basic idea in herd immunity is that by having beyond a threshold, a certain number of people beyond a threshold vaccinated, that there just isn't essentially living space for the virus within the population. If it enters, it'll fizzle out quickly because it's a hostile environment for the virus, essentially. But what that threshold is, in order to achieve that depends also on the infectiousness of the virus, doesn't it?
Yeah. So if, like, say that the first chart where it was about 4 out of the 11 people, or 4 out of the 14 people were being infected. So that kind of gives you an idea of that you need 7 out of 11, roughly, to kind of give it a choke hold on it, so it doesn't get a chance to go forward. But if it's a case that it could infect everybody, then you need everybody vaccinated.
Okay.
Like by one person. So
crazy infection.
That doesn't happen. That's never going to happen, hopefully. But yeah. So the levels are probably up and around the 70 to 90% of people needing to be vaccinated for this.
Okay.
With a vaccine
of
transmission.
Yeah.
Of the whole population.
And so,
because
that becomes another reason why increased transmissibility is concerning. So we have 2 reasons to be worried about increased transmissibility. One is that as of today, our vaccination rollout has only reached a certain point. And that means that there's a large number of individuals in this country, a huge population, that have either received no vaccine yet or have only received one. So they're not 1 dose of a 2-dose program. So they're not fully vaccinated. So there's a large population there that are not yet vaccinated. So increased transmissibility matters just for that reason on its own. But then also it matters in terms of what we need to do to achieve herd immunity, which is the long-term plan.
Yeah. But I suppose the only good thing we'll say from Irish figures is our uptake levels of the vaccine have been incredibly high, higher than anybody could really have hoped for. Like you're talking nearly 100% uptakes in age groups. And if that can continue down the line, we could have absolutely nothing to worry about. The worry is that if you're left with a situation where you have even 95% of people, 90% of people covered, but you have a high number of imports, then you can get a situation where you could end up with maybe 3% of people infected. And that's just back to last March. But if we keep the rate going through all our age groups, we'll definitely come out the end. Of course, the question is, when do we get there, which is the frustrating bit, because we still don't have an approved vaccine for the under 12s.
So we have a question also from Aoife O'Brien, who is a journalist with the Times of Ireland. And so she writes that last Friday we got the information that there were 72 cases of the B.1617 variant that have been detected here. And there was also information about reduced efficacy with the first dose of the vaccine against this variant, that you need the 2 doses to be fully covered. So she asked the question then, can we continue our reopening plan with what is currently in the country? And at what level of spread do we need to change our plan and either alter it or halt it? Maybe, Paul, you have a comment, but there might be other members here who have other members of the group who want to come in as well. But maybe Paul first.
I don't see. The problem is we don't know how many of them are in mandatory quarantine. If they're in mandatory quarantine, it's not that who cares. Obviously, it matters, but it's not as impactful. If it's in a cluster and public health have control of that cluster, that's a different story again. If there are cases where we have no idea where they come from, even a small number of them is very concerning. It's just about if we have full knowledge of where things are, but that's probably where the NVRL has done a really good job up until the hack anyway. That didn't directly affect them, but they got up to 30% of cases sequenced, which means they know which variants they are in 30% of the cases. But we also know that 2/3 of the other cases are from close contacts of confirmed cases. So we should have a decent knowledge of where what variants are. We the public don't know anymore. I know HSE channels are slowed down as well, but we're not in a position to advise on that, other than say, you know, they would have the knowledge and they'd know. But anything that's community or they can't trace it, it's just a worry. Because we saw how quickly the situation changed.
Yeah. But it's extremely important that, you know, the difference between catching something in mandatory hotel quarantine or entering that same case entering the country in another way, because we've seen this already. And I think Jerry Killeen made the point very well that there was a great success with the P1 variant, which was another variant of concern that we're very worried about. But it entered this country. But it was contained again. So, you know, we so far have managed to not let that spread in this country. So there's a big difference between importing cases into quarantine and importing them otherwise. So we can have much greater freedoms within the country, which I think is a really important point. So, you know, if we were quarantining arrivals, the opening plan domestically could be unaffected. And did anybody else want to come in?
Well, the opening plan for the outdoor stuff might be unaffected. The indoor stuff is it's as nearly as insane as Christmas. The 1 meter,
well, yes.
You cannot ventilate yourself out of 1 meter.
Yeah. And I think, and there's another, I mean, and the other thing is that, and I think Orla Hegarty has been really good. Orla Hegarty of UCD has been really good on making this point that, you know, when they talk about reopening certain sectors, they're not attaching any criteria to the standards of that, you know. So if you open gyms and hairdressers and pubs, but you're not asking them to, before they do so, you know, meet certain standards in terms of ventilation, it just doesn't make sense. So one gym might be with big wide open windows and another one might be in a sweaty basement, and they're not the same thing. Just because they're both gyms doesn't mean they can both open on the same day. So does anybody else want to come in there? I've got other questions as well. I've got a couple more questions also from Aoife O'Brien. Yes, Ivan, please.
I think just to make the point, I think it's clear that we will have to look at the opening up of our indoor section. You know, as Paul has really explained very well, that the vaccine is just one layer of protection. It's a very important layer, but we need all the other layers as well, and we are asking too much of the vaccine if we pursued with the current opening up plan for the indoor section. Given that we know that obviously there's a high proportion of the population still unvaccinated, and there's a further high proportion of people in their 60s who've just had one dose of the AstraZeneca vaccine. So I think it would be reckless, akin to what we did before Christmas, if we proceed with the current opening up plans for the indoor sectors.
So there is a question. So there's a couple of questions are linked there to things that have been said. So Aoife O'Brien is also asking, should we change our vaccination plan given that one dose is less effective against this new variant? I'm not sure there is scope to change the vaccination plan. Jerry?
Thanks, Aoife. Yeah, I think you've hit the nail on the head there. You know, there's only so much we can do with vaccines for which we've got a limited supply rate. So, and the vaccine rollout has generally speaking gone well, and we couldn't have asked for better vaccines. So there's limits to what we can do about that, and we've had it as good on that front as we possibly could have hoped for. So the question is, what do we do with all the other things? And one of the things, there's two things I'm concerned about. First of all, I agree with all the questions from Aoife and Nessa and some of our other attendees about this being a rushed reopening, and also a reopening which is mired in conflicts of interest. You know, to have Board Fáilte drafting the plans for reopening our indoor hospitality is not the correct way to do it. You know, this needs to be some objective oversight. And the danger is, there's two dangers. First of all, is that we get ourselves into a fourth wave, and kind of the rest of the country follows Limerick into what it's starting to experience, follows Bolton into what it's experiencing. But the other really big danger is that by easing off our decline a little bit too early, we, instead of reaching a stage where there's no COVID and occasional outbreaks and we can manage those, instead we just ease off a little bit too early and cruise into stable endemic transmission. And if we have stable endemic transmission, it's going to be very hard to sleep at night, because then you've got an endemic pathogen that's still evolving in the face of strong pressure from high coverage of a vaccine that we've all come to depend on. And that's really a recipe
explain
for
that
trouble.
more, Terry?
Sure, if you want to.
Because I think a lot of people think about endemic as being not quite a friendly situation, but one that doesn't bother you. You know, people think that the word endemic means it's there and it doesn't matter. So I think, and I've heard a lot of people saying it's endemic, don't worry about it, forget about it. I think we need to explain a bit more what we mean and what's happening when we talk about something being endemic.
Sure. So endemic means that something is around, it goes through stable transmission chains, perhaps at low levels, but when you get it, you really might not enjoy it. Like, I mean, I've had endemic malaria a couple of times. I've had endemic schistosomiasis, giardia, and I can tell you I really didn't enjoy any of those. It's not the happy place that some would have you believe. And not all pathogens evolve towards lower virulence. Many of them go up through the gears, and that seems to be the case with COVID, particularly when it's linked, when virulence is linked to transmissibility. So, and when people talk about evolving towards more less virulent forms, it's usually not the pathogen that evolves; it's the people, and that's really bad news for the people who are selected out of the gene pool. So it's not always a happy place, and there's a big difference between a trajectory that is just steep enough to get you down to zero and one that levels off at a stable, slow burn position. And, I've lived with that for many years of my life, and, I would avoid that if at all possible.
Yeah.
So, going after it, taking this opportunity to go after it over the summer, and, if we have outbreaks, there's small outbreaks and the public health teams can deal with it. But if you leave it at, 300-400 cases a day, there's limits to what we can expect.
Yeah. And I think it's worth pointing out that and contrary to what the impression you might get from some kind of science fiction TV programs and things like that, individuals don't evolve. Like, evolution doesn't happen by me changing and suddenly being better at fighting a virus. Evolution happens by people dying and other people not dying. It's not a pleasant thing. It is not something. It's not an outcome we ought to be counting on. And just as you mentioned there, though, there's a few questions. I'm trying to get around to them all. Just one person asks about seasonality. So they go, surely June isn't the same as December or January. Does anybody want to talk about that?
Yeah, I mean, it's not the same, but it doesn't mean it's not good. Qatar at the moment have a massive vaccination rollout of Pfizer and Moderna. Their cases are going up. It's Brazil in Manaus. The cases and hospitalizations are going back up again. It's not as bad as you get in winter, but that's just tells you how bad we could be going into a winter situation. Not how much easier it will be in summer. As long as the base, so for example, if we take a virus that might give you four people infected over your winter period, that might drop back down to 3 over the summer. That's still more than 1. Whereas with flu, what will tend to happen is you could go from 1.2 down to under 1 and it dies off. So that's why flu, but it still niggles there at the very bottom, and then winter it'll pop back up again and floats like that. And that's something that we can live with, kind of, if it's just that over 1 and under 1. But when it's between 2 to 3 or 3 to 4 and back up and down like that, it's just not sustainable. Then you're depending on people getting infected and just waiting for their immunity to wane for it to come back again. It's not pleasant. It's literally how we'd evolve humans to a better select few people.
So just because SARS-CoV-2 is that bit more infectious, like good bit more infectious than something like flu, it means you just go from really bad in the winter to just bad in the summer. Whereas flu, it can be really bad in the winter and die out over summer because the number drops less than 1. And another, I mean, some things and other things that help, of course, in the summer is that it's easier to be outside and it's easier to have your windows open. And I encourage everybody to do that as much as possible, because that does seem to be really important. There's also another question about what's happening in Limerick, and it was mentioned there already. You know, do we have any idea? Is this B.1617? Is it B.1617? Do we know? Does it make a difference to how we deal with that situation? Is there any?
I'm not aware. I think I did see some notes from Limerick going up onto the surveillance system for that thing. So there are cases in a few places around the country. I just don't know whether those particular outbreaks are linked or not. But yeah, there has been a few on the GIS aid system.
I think Anthony maybe wanted to come in there as well.
Yeah, as far as I know, it hasn't been reported what the strain is, but it doesn't actually make much difference. Your response is not going to be driven by the strain. Your response is going to be driven by the number of cases, by the situations in which it's arising. And we're really talking about public health responses, ramping up vaccination. One of the questions been asked, I think, is should there be local restrictions in Limerick? And the answer, depending on what the public health people say, is we should certainly be thinking about it. I don't know if we should do it or not, but it should be one of the options in a control mechanism. And at the moment, it isn't. At the moment, all our actions are done at national level, which is not necessarily the best way to go forward.
Yeah. So there's a couple of other questions that are a bit different, and I also wanted to talk about the idea of vaccine efficacy if we have time. But there is one question about it's again about the vaccines and about the dosing intervals, and I just think I'm not sure that we're in a position to talk about the dosing intervals. I think these are done based on trials and certain amount of the investigations that are done, and the intervals are recommended based on maximizing the efficacy. So I don't know if anybody has anything more to add on that. So Jerry.
Yeah, I just think I've heard the term good news used this week, and I think I'd like to use more measured terminology. I think we're all relieved that while there does appear to be an attenuation of vaccine efficacy and effectiveness, it's not as big as it could have been. Is it big enough to be significant? Yes. Does it affect our plans? Yes, it does. Is it reason for panic? No. It's nothing that we can't cope with. But I think it's important that we just treat this as, a step in a process. Evolution is a process. And, we haven't received a direct hit, but it's certainly a shot across the bows. And we should pay attention to that and plan for the fact that this is an ongoing process. And we don't know quite what cards this virus has up its sleeves. And in fact, the virus itself doesn't. It's currently figuring out what its full genomic repertoire is, and that's going to take a few years.
Yeah, no, it's there's a question I just would do quickly. Somebody's asked, is the idea of having a by-election in July, is this crazy? I suppose it goes in with the category of other kinds of openings. Any particular views on that? So
yes.
It's probably, pardon?
Yes, it is.
Yes, it's crazy. Yeah, so it's, I suppose, with and there's also a question, about opening.
Yeah.
Pardon?
Just don't open your door.
Yeah, well, I think it comes and don't open your door kind of fits with the next question, which was, in terms of opening travel, the idea of opening travel with the UK and then, opening travel with Europe. And is this okay? This is a bit like opening your door to the politician, opening your door to the virus, to the new variants.
It's really high risk. It's really high risk. We might get away with it, but it's a very substantial risk. We know there are new variants spreading in Europe. There are new variants spreading in the United Kingdom. We know there are relatively high case rates in a number of European countries. There's a significant risk, as we've seen with what's come into our own mandatory hotel quarantine up to now, that enough cases will be re-imported into Ireland to keep this going at the current rate. And that's not where any of us want to be.
Yeah. And as we will get on to the vaccine efficacy soon, we will do that quickly. But, as we allow more virus to circulate, we allow more evolution to happen, and we keep shifting the goalposts in a sense, because we can make new versions of the vaccines that will deal effectively with the new variants. But of course, all of that takes time, and we leave ourselves in a situation of being constantly behind. I think Andrew Kunzman wanted to come in here as well. Andrew?
Thanks very much. Yeah, it's just a point about learning from the experiences of the North. We're a few weeks ahead in terms of the vaccine rollout and a few weeks ahead in terms of reopening. And the next few weeks, we'll get that signal of what will happen if you reopen when large parts of the young population haven't been vaccinated yet and some people haven't had their second dose. I mean, I personally feel that this reopening is a few weeks too early for here. I mean, even if you do accept a level of spread, it's still a 2 weeks or so too early before we've got enough young people vaccinated so that it can have an impact on spread. I think my prediction, and I mean, it's not an official prediction, would be that we'll see cases rise quite quickly over the next few weeks in young, unvaccinated people. And it's just about that race between getting that vaccine out as quickly as possible and preventing that not having a knock-on impact on older adults. So we'll see what happens. I mean, I was out and about the other day and a lot of people were still eating outside, which was good to see. So it is good that that message of outside is safer is coming through, and a lot of places have their doors and windows open. So people are taking it a bit more seriously, which is good to see, but there is still that risk. And I think if I was in the South, I'd be watching closely at what happens and learning from that, because that can be the early warning signal.
And sorry.
No, go ahead.
So you're quite a bit ahead of us in terms of the vaccination rollout as well. So yes. In terms of how far your vaccination program has progressed, and there is a definite temptation. We see things opening in the North, we see things opening in Great Britain, and there's a temptation to compare ourselves and to say, well, if they're opening, why can't we? But we have to remember we're not in the same context as well. And you mentioned the spread among young people, and of course we know that the percentages of individuals who are seriously affected are lower in those younger people, which is good news. But once you have really wide spread of the virus, those become large numbers of people infected, and a small percentage of a very large number is still a large number, and that can't be ignored either.
Yeah, certainly. And I mean, the risks of long-term complications is still present in younger adults. And the worst thing I fear is people getting ill a week or so before they're about to get their vaccine and then having these lasting impacts that affect them for an unknown period of time, when a week or two later they might have been spared from that. So it is important to still be cautious and be aware that cases do lead to hospitalizations. The people who aren't vaccinated, that are older or more vulnerable, the more chance they have of coming into contact with a young person that's unvaccinated that unfortunately catches it, then the more chances we'll test that and find the virus will find the people who haven't been vaccinated or who the vaccine hasn't worked quite as well with.
Yeah. I mean, it's such an extremely risky strategy in the UK, I think, opening up right now. And we should avoid making the same mistake. And they're taking a huge risk. But it also means that in a few weeks, we will know more as well. I mean, we'll be able to learn from that kind of awful experiment that's currently happening. If we just have a few minutes left, and I just wanted to get on to the point of vaccine efficacy, because this is another thing that's come up in the last week, talking about the B.1617 variant, because there was this information about the vaccine efficacy and reduced efficacy with a single dose of either of the vaccines available, and that you didn't get a good protection until you had your 2 doses, and those have their opportunity to take effect in you. You don't get magically protected once the vaccine is stuck into your arm. It has to elicit an immune response in your body. But could we talk a bit about the different vaccine efficacy and effectiveness, and what this means, and what do we know, and how does that impact the decisions we make as well?
Yeah, sure. If you want to bring up the next slide there.
Ben, yes, great.
So this is the vaccine impacts from the UK Public Health England report, comparing Pfizer and AstraZeneca for both B.117 and the B.1617, the first identified in India. So in dose 1, we can see Pfizer has a range of people still in both situations, a range of people still left unprotected as far as cases are concerned.
What are the colours? Sorry, Paul. What are the colours?
The green is protected. The blue is the range of which is the confidence interval on the actual effectiveness.
Okay.
Yeah, well, so that's the actual. So the numbers that came out would say, so when they said 50% for B.117, it would be the middle of that blue box there, and then it's just for colours. So that dropped to 30% for dose 1 with the newer variant, which is that larger on the third row, the larger gap, big gap there. But there's lots of uncertainty in there, as you can kind of see that the range, the confidence interval of what's known. But the people in the orange are the portion who are unprotected after 1 dose. In both cases, is still quite high. For AstraZeneca, it's the same type of thing after dose 1, except the time you have to spend between dose 1 and AstraZeneca is 12 weeks. The time you have on dose 1 with Pfizer is only 3 to 4 weeks. So you get to dose 2 quicker. You also get to protection after dose 2 much quicker with Pfizer. So it hits. So you see there how small the orange bit is for dose 2 of Pfizer in both cases. So now while it's small, that's still, it looks like it's around double the amount of people who are unprotected. So, for example, with B.117. But this is just for cases, so we can't automatically translate that into what it means for deaths. But in general, you can see there is the main problem here has been for dose 1 with AstraZeneca because of the length of time and it's a big drop, and the amount of people who are left unprotected. It doesn't allow for a lot of room. Dose 2, you can see again with AstraZeneca, there was the worry about that it will only hit a certain level. But you can see there with the uncertainty that the ones that were 100% sure, it might not be that difference longer term, but we have to get there, and we simply won't know until we get more data. Again, this is just for cases. We won't know the severe outcomes for about a month, and this is the real problem with our patients. We won't know. But what we could do is, if we look on the next slide, if we look what came out of Qatar. Now, in Qatar, it was only for Pfizer, and they only used mRNAs. And we look at dose 1 and dose 2 effects. So we can see for infection, which is just any infection, even ones that are not symptomatic, dose 1 isn't really that powerful, which we've seen again. And now the comparison here isn't for the variant found in Africa, in India, but for the one first found in South Africa. Now, I try and compare this is the tortoise and the hare. So the one found in India is like the hare. It's really, really fast, but it looks like the vaccines work really well for it. The one from South Africa, the B.1351, is about as transmissible maybe as the original one, maybe a tiny bit more. So it's not even as transmissible as B.117, but it can impact even after dose 2 of the vaccine on transmission. And you see there, dose 1 of Pfizer had absolutely no impact on severe outcomes in Qatar for the variant first found in South Africa, whereas for dose 1 it did actually have for B.1617 it did have an impact. So again, we won't know this for the variant first found in India for a few months, for a month, when deaths would normally start to come in. So this is how long it takes for us to actually know what's going on, and why we're always acting the wrong around. Because many of those people who will die will only have been affected in the last week, and that's how long it's going to take for it to come true in figures.
Okay. Yeah.
I suppose on the very last slide, I suppose there's this quick sketch of how effective we really need these vaccines to be, and even if. So in Israel, Pfizer say we've had a 30-fold decrease in chance of death. So where there would have been 30, there's now just 1. So in Ireland, so if we take the original situation, we look at the data, we could have been facing 47,000 deaths had we done the let's let it rip approach, and that's minimum because that's not even accounting the bumps you get from hospitals being overrun. With that, it drops to 1,500, which is still very bad. But that's not taking into account the fact that vaccines really do reduce transmission, especially the mRNAs. So if they're 75% effective at blocking transmission, you can really reduce that so that there's probably less than 150 deaths in the fully vaccinated population, which would be just incredible. And also less chance of variants because less chances for it to mutate. So whether these values are higher or lower will depend on how the vaccine turns out, how many variants show up. The frequency of importing cases, if you import cases, you end up with, because it doesn't just disappear, it spreads through a certain percentage, and the amount of imports you have defines how far that will spread. And like I said, the most important things we can look at from the beginning is public health interventions to control it so it can't spread itself naturally. Herd immunity is kind of, even in vaccine context, I was kind of just obsessed with just the maths. If you supplement that with certain practices like public health containment, you don't have to worry about herd immunity, because it just means you get those people, outbreak management, to make sure that it doesn't get to spread. And also the simple thing, the best thing is, so we saw there the time infecting was between 5 to 7 days. By changing culture where you don't go to work when you're sick, when you've got COVID-like symptoms, you can cut that down to just the 2.5 days, and that will make as much difference as some of the vaccines that are on the market. Just staying to transmission chains, just staying at home when sick is still the single most impactful.
And it's such a simple thing. It's a bit of a culture change, isn't it? Like, so and so, aren't they great? They came in anyway. They're so dedicated to their work, rather than saying, now they've knocked off half the office. Sorry, Jerry.
Yeah, I mean that it sounds like a joke, but that actually happened to me on my last trip to Tanzania in January. I was lucky. I moved to another branch about a week before there was an outbreak in the office. 2 of my friends ended up laid out absolutely flat. One said goodbye to his family because he thought he was finished. And, those are the real consequences of those cultural changes that we need to make and that we need to invest in. I mean, people need mandatory sick pay. There's no two ways. It was the right thing to do long before COVID. It's a sad reflection on our societal values that we don't have that anyway. It should be a part of who we are, and now we've got the best reason in the world to do it. In everybody's interest anyway. Yeah.
A lot of these things, I mean, everything's pointing in the same direction, isn't it? And a lot of these things that are good social policy, are also good for the whole country. And I think in other sense, everything today for me as well is pointing in the same direction, is that we need to err on the side of caution here, that the cost of overreacting, if it were to be an overreaction, would be that we delay things by a few weeks. That, we in a few weeks' time, we will have much more clarity regarding this B.1617 variant. The reason we'll have more clarity is because they're not being cautious in the UK. And I think we are going to see the effects of it there. And it will, and because they are also monitoring things closely, they have very good genomic surveillance, they have very good national health system service. We will have good quality information from that country, and we'll know much better. And for the sake of waiting those few weeks, we avoid the risk of letting things go really badly again, and and avoid jeopardizing the holidays within Ireland that people are planning. You know, that, and I think people are very much looking forward to because of the year and a bit that we've just had. And so everything in terms of the potential transmissibility, what we know about the suggested, the early results that suggest that the single dose of the vaccine is not going to make a significant enough impact on cases and the outcomes of those cases. And, you know, that all of these things put together mean that we really need to be cautious right now. There's a lot at stake in that sense, that, you know, we have got ourselves into a relatively good position, and we should not risk that.
Yeah, and I suppose just on that, when we keep going on this one found in India, the B.1617.2, but the one found in South Africa is still there. Just because it's not as fast doesn't mean it doesn't have concern, because when we go back to normal, it's as fast as the original, which was extremely fast, more than we've been used to. And so if we go back to normal lives, or meeting 15 people, and I don't know about anyone else, but when we go back to normal, it's going to go more than that, because it's been too long without seeing enough people. And we're going to be hit with that if we let it in and let it grow. And if we look at cases now in South Africa, they're going back up again. If we look in cases in Qatar, they're stabilizing and going up, even though they've got a considerably higher vaccine rollout than anybody else. There's more than just the one our next door neighbours. So, like I said, UK because they've got such good surveillance systems, we can kind of have a little bit more less cautious sometimes, maybe not right now, but at other times with what comes in from that country. But from vast majority of Europe, they're just simply not doing the type of monitoring that the UK are doing.
Thanks. And we just have a question. I think it might be a good one to wrap up with. I think it's one that Jerry Colleen can take. It's to do with the mandatory hotel quarantine and these kinds of policies, and you know, how effective are these, and can we defend these policies in the context of Europe that's dying to open up?
Thanks, Aoife. Yeah, well, first of all, let's remember that Europe has been a policy basket case on this issue right from the outset. You know, it's a long list of mistakes, and when we refer to best practice, we tend to refer to Europe rather than looking at real international best practice. You know, but I think we've done enough in this country to learn not just from our mistakes, but also from the things that we got right. You know, I love the idea of the analogy of opening doors and closing doors. We were prepared to close the door on P1. We were prepared to ask our Brazilian friends and family members and Irish people living in Brazil, we were prepared to ask them to do mandatory hotel quarantine for 2 weeks. And our public health team were able to snuff out the epidemics that we did have, or the small outbreaks that we did have in the country. So we got that right. Now, but if we compare that with B.117, that was a decision we were never prepared to make. We were never prepared to close the door on our friends, our family members, we haven't bitten the bullet on that one yet to give our public health. And now B.117 is still with us. You know, how many people have died and how many people have lost their jobs? How many people will be carrying long COVID indefinitely because we weren't prepared to impose mandatory hotel quarantine on our nearest neighbors, which is a really, really tough choice. But it's a clear choice. It's a choice that we do need to make. None of us can manufacture a time machine if we get this wrong. There's no way to go back if we get up to huge levels of something of this level of infectiousness. So they're clear choices. They're difficult choices. And I think we need to rely on foresight rather than hindsight, but also keep an eye on P1 as an example, because right now, Manaus is heading into its third surge. That means they're on their third tour around the herd immunity track. And there's no sign of this letting up. And that's what endemicity looks like. That's what a lot of the diseases I'm familiar with look like. And sometimes there's no way back. I've been through epidemics that none of us knew how to stop. I've been through endemicity over the long term and getting tired of testing and tired of being careful and dealing with the consequences of that. So, you know, let's just apply our common sense and put wishful thinking aside and really just be smart about this.
Thanks, Jerry. And I think it's worth mentioning that it's, the quarantine doesn't apply to people according to their nationality. It applies to people according to whether or not they're traveling or not. You know, it would apply equally to Irish people returning, as it should. I think we've had a very good session, and so really huge thanks to Paul Dempsey, who has been helping us a lot in understanding the really important concepts that we need to think about when we're making the decisions we need to make over the next few weeks. And I think that's been really useful, a really useful session for the general public in terms of understanding what's at stake and, you know, why these discussions matter and why these various technical features matter. And I think, so we see now, I think that I think everything points in the same direction, that it's very important to protect the situation we have in the country, such as it is, that, it doesn't really matter how much people would love to be going on a summer holiday in the Mediterranean or further afield. The virus doesn't care that you really would like to do that. What matters really is that we protect the situation inside the country, because we've seen already earlier this year the really devastating consequences of relaxing the brakes at the wrong time and opening at the wrong time and in the wrong context. We have an early warning system that we've been lucky. We have an early warning system in terms of what's happening in the UK. We can benefit from the really good analysis that's been done there, the work of SAGE and IndySAGE and Public Health England, who are monitoring this new variant and who are releasing information, letting us know what's going on. And I think we should really heed that and not make a mistake and err on the side of caution. And if it does turn out that this new variant is not really worrying, then we can all breathe a sigh of relief. But we will have only delayed ourselves very slightly. And I think that would be the message that I hope gets through to the people making the decisions. So thank you very much to everybody who participated today, Paul and Jerry and Anthony and Andrew, and Ivan, had really important contributions, and everybody else. Thank you very much to the public for your questions, and to everybody who's listening through the streaming services as well. I hope you found this useful. Thank you.